what's happening in the commercial space is because there is still and once was the wild, wild west of out-of-network reimbursement rates. I think insurance companies are really starting to tighten up in our industry, where I think where was once this, like, if you have out-of-network benefits, you can go wherever, right? Like, that's what a PPO is. That's what out-of-network is. I've seen recently multiple states say, if you have a PPO, even in this state, you cannot receive substance use treatment out of the state. And I'm like, that's crazy, because that's literally what a PPO should allow them to do. So when that comes, that's when outcomes and data is going to be the most important, because how am I as an in-network provider going to differentiate myself from another in-network provider? I'm going to need the data and the outcomes to go to that insurance company to want to renegotiate my rate and say why I deserve for it to be more than all of these other programs that don't have the data that I may have. So outcomes-based measurement, hugely important.
It's a long-term game.
Yeah, it really is. But I'm seeing it already. It beginning to be, even just going on LinkedIn. Like, and again, I don't have this huge amount of years in the space, so I don't know if this was always happening, but I always look forward to the end of Q1 because I always look forward to seeing programs outcome data.
The last 4 years, how have you seen the evolution of behavioral health and substance abuse post-COVID?
I mean, I think the easy answer would be that it's certainly been exacerbated. I think the data and everything would suggest that, during the time of quarantine and all that, substance use dependence, alcoholism, a lot of that certainly shot up. It's hard for me to say as far as in a comparative way to pre-COVID, because I didn't work in the space then. I got sober myself during COVID. So I'll certainly say that within the last 4 years following the pandemic, there's certainly been a shift in a lot more of co-occurring presentations. You know what I mean? So I think a lot of individuals are seeking help from more than just your primary diagnosis, if anything, SUD, right? So like your primary, stimulant disorders or opioid disorders, alcohol use disorder. And there is certainly been an exacerbation of, with a co-occurring anxiety or depression. And I don't know if that's a direct relation to the pandemic. It very well may be. I think also in the market that I'm in the Northeast, where treatment is, I'll say, oversaturated almost, very few individuals are seeking treatment for the first time that we see, right? So like a lot of our individuals are those who have been to several treatment centers, whether that's 2 or whether that's 22. Like we see everything in between. And I think those individuals who have been to treatment a bunch of times before, especially their family members, like I think there's this real fundamental desire for there to almost be a co-occurring diagnosis. They want some sort of explanation, both the client as well as the family, of this cannot just be because our brother, son, father, whomever, right? Mother, daughter, sister. It can't just be because they like getting high this much or they love getting high this much, even if they are relatively educated on the disease model of addiction. And that's where I think a lot of individuals are hoping almost, right, that there is some sort of explanatory, co-occurring diagnosis of anxiety and depression, and that's being the underlying cause that continues to, continue to kind of keep their loved one in an active cycle of addiction. And I think in the last 4 years, the industry has caught up with that. You know what I mean? Like right now in the Northeast area, we had already hundreds of primary substance use programs, and the majority are all going into a primary mental health service as well. So they're getting their dual licenses at the outpatient, inpatient, and residential level of care. So I would certainly say that that's probably a big result from the pandemic, and also just of the shift in, insurance reimbursement rates and payer rates, and mental health being right now like such a, I don't want to say a buzzword in a way that cheapens the significance of it, but that's really what it is. It's very few programs that are in the area that I'm in are primary substance use and staying there. The majority are also becoming dual licensed and becoming a dual diagnosis program.
I just want to quickly ask if you find this episode insightful. And if you have, I'd be so grateful if you can quickly subscribe to this channel. Please subscribe so that we can ensure that no one gets left behind in the value-based future of healthcare. With family members, and it sounds like the public in general, being more aware about mental health, it sounds like, and a little bit more informed in that sense. Um, does that change your messaging and your marketing?
I think so. For me, it's important to get a baseline. Anytime I'm working with an individual or a family member, it's important for me to get a baseline about what their knowledge is about the situation, because they have naturally such a subjective look at their own loved one that they're calling in regards to resources for, or the person calling themselves for resources. Um, so it's important for me to first get a baseline, because I still feel like, again, substance use different, right? Very few people are going for their first time into a form of substance use treatment, or at the very least, right, popular culture has had, Alcoholics Anonymous in movies forever, right, and rehab and things like that. But I think with mental health, it's important to almost get this fundamental understanding that a lot of times the general public, it's very much in your face now, right? Like mental health awareness, and let's discuss this. Let's make this, let's make services equitable for our people. But then at the other time, it's like, all right, but what does mental health treatment look like to the average person? And they still think it looks in one of two ways. It's either I sit and lay on a couch and someone on an armchair sits there and like writes down like whatever it is we're discussing, like your one-on-one individual psychotherapy, or and depending on how old the person is that I'm talking to, I'll mention One Flew Over a Cuckoo's Nest if they're old enough to understand the reference of the Jack Nicholson movie, because that's the other form, I think. Like, so my job working as a marketer in behavioral health is to inform that inpatient is not the only form, right? There are these residentials, PHP, IOP, GOP levels of care. So when a family member is reaching out, or when a patient is reaching out, or a loved one, it's like, hey, have you ever sought help for your mental health before? And they say, yeah, I've seen a therapist. And I'm like, okay, so you understand this level, right? Or when I ask them, have you ever been to anywhere for your mental health for treatment? And they mention being in psychosis before and being in a 72-hour, what we call like a 302 here in Pennsylvania, which is an involuntary hold for 72 hours. Um, yeah, I was 302 before at Horsham Clinic or something, which is out here in one of the collar counties of Philadelphia in Montgomery County, Pennsylvania. I've been 302 before at Horsham. So I'm like, okay, so this person thinks that anything I'm going to maybe want to encourage they do for their help, their experiences are valid, but I was put somewhere against my will, held there for 3 days. I'm not doing that again. And then again, I'm not asking a person to come to our program or any program that I work with for 45 minutes worth of a session, at the lower levels of care. So I do think families are more involved. I do think clients are more involved initially. And there needs to be this understanding of baseline in what I do as a marketer, because unfortunately, not everyone does this role in the country, in the world, maybe, with the proper ethics that really need to be taken into consideration when a vulnerable person is coming to you and asking for help. I don't know, but very few people ever call me and offer to give me their name, date of birth, and member ID from their insurance number. But that's the three pieces of information that I'm asking for after collecting this baseline information. So there's certainly this trust that needs to happen, this transparency that needs to exist. And I think in order for me to do that equitably, the first thing I'm doing is just getting, again, a baseline understanding of, I'm not jumping right into this about explaining to you what our partial program offers if you have no idea what it is I'm even talking about. So where are they at? What are they interested in doing? And then finding a way to market my program, other programs, just any form of solution for the person at that point is the most important thing for me.
You talk about ethical marketing.
Ethical marketing in my role, it's simple. It really is. It should be. The commercial industry is an incredibly, it's an affluent industry, I guess you can say, right? Like there's a lot of money being made. There's a lot of reimbursement rates being thrown around. Ethical marketing to me is honesty and transparency above all things, right? If I'm telling a client something that's not true because I want that client to do something that's benefiting me, that's unethical marketing. If I'm telling that client or my program even, hey, this person's appropriate clinically to be at our program, but I know deep down that that's not true, that's unethical marketing. If I'm offering things that I know I should not be offering to a person because it's illegal or because it is considered to be patient brokering. I know that I'm dabbling into what is considered unethical marketing. Um, the unfortunate reality of it is that it exists, and I think it exists, and that's why the private treatment industry, especially, has gotten a negative view on it, and that without naming specific programs, they're all unfortunately easily able to be found on Google going back 20 years. But what was happening, obviously, is that there were these insane reimbursement rates where individuals were doing whatever they can in order to, get individuals into treatment, to take advantage of those reimbursement rates and to make that amount of money off of that person. And the incentives to do so are still insane. I think a lot of salaries are such a high number where in order to ultimately prove up to it, you have to be putting in a lot more people into treatment than you'd otherwise would have with a more modest salary. So I think that's certainly leverage, if you will, to unethical marketing. I think a lot of people have been unethically marketed themselves, myself included. Um, when I was out there getting high still, like I was put into a level of care a day after an overdose. That was not an appropriate level of care for me to be at. I didn't know any better at the time, but nevertheless, like I don't blame the person who put me there, but I think I was kind of a byproduct of the way that he ultimately was either maybe put into treatment himself or the pressure of, you make this much money, you need to put people in treatment. You need to produce results, right? And back to the issue is such an oversaturated market that this area has certainly become. Clients don't have one or two options. Where we are, there's no such thing as like, well, I can only go to place A or place B, like, and the clients know it. So they don't like what A, B, C, or D tell them. Like they're going to keep calling until they find a place who gives them exactly what it is that they want. And the programs and the marketers, they realize that. So it's an incredibly fast acting, industry, what we do. Like my phone is always on me. It kind of has to be because, like I can't afford to miss the opportunity of my phone ringing with someone who needs resources and help. Um, because that's kind of how quickly, unfortunately, it can really kind of come and go until that person's on to calling the next place. So ethical marketing is just really, doing what's in the best interest of the client, not what's in the best interest of the marketer, not what's in the best interest of the marketer's program, not what's in the best interest of the marketer's referral sources, because this business is naturally a lot of, you know, we send to programs who also send to us, you know what I mean? And it's not in like a quid pro quo way. It really is just more so in this, it's kind of a give and take naturally, right? We identify programs that align with our core values of our program, and those are the ones with whom we work. But it is a KPI thing. It is a key performance indicator. It is a metrics based program or industry rather, where we realize that if we've been, if we have a program who sent a dozen to our two, like, you know what I mean? Like we need to, it is a business, right? So like we need to look into why that may be. But at the end of the day, it's if I'm trying to, herd people in a direction because it benefits me, right? And it's not what is best for them, then that's a problem. Then that's unethical marketing to me. And there's a way to do it where both make out, right? Like if I know I have a program that I work very well with, that I believe in their clinical offering, and it just so happens that it's a program that I benefit from in a business relationship with the reciprocity, there's certainly nothing wrong with that, right? But I've unfortunately heard stories and have seen individuals who express, I have severe anxiety and cannot be in an area that's incredibly like rural or anything because it's like it's not good for me, right? And then I've found that they've ended up in programs that are literally in the middle of the mountains, in the woods, in a very desolate area. And I'm like, okay, that person's best interest was not kept in mind, right? So there is always the possibility for miscommunication, or that may have been missed. I don't know. But unfortunately, oftentimes though it's a matter of unethical marketing where a person has their best interest in mind first, their referral partners, their programs, not the client. And I can't get down with that. I can't get down with the idea of me exploiting a vulnerable person who's calling me at 2 a.m. needing help. You know what I mean? And putting their trust in me to get them that form of help, and one that they're ultimately in the best interest of receiving. If I'm thinking about what's best for me or where am I at and things like that, like I'm already kind of off to a bad start.
So, how do you make that determination? How do you help guide patients about the best placement for them?
So I think experience is the best thing that you need first. Like I'm only a 3.5 year tenured marketer in an industry where, hell, I've had the privilege of like golfing with or having conversations with and lunches with people who have 20, 30 years in this industry. And it's awesome. It's fascinating. I absorb it up. But 3.5 years in this market specifically, in like the Philadelphia area and the New Jersey, Pennsylvania area, is not a short period of time in this, because when you do this work, you're immediately exposed to a lot. So, I think me making sure that I gain the experience that I do, right? And what I have learned is that not everyone can or will work with everybody. I remember being a new marketer and thinking every person is someone that I should meet with or have to meet with or can. And it's just like, I realize now, like, 3.5 years in, like, that's not the case, right? Like, not everyone can work with everybody. It's nice to play nicely in the sandbox with everybody, but we only have so much essential, business or transactions and referrals that we can send between each other. So I think like what I do is I make sure that I at least align with the clinical programming first and foremost. Like, I'm so fortunate to have started in this industry, and I've only worked for 2 programs in this industry so far. And both of them are incredible, and they're great programs for me to have really gotten my start at, and then my next level up in my career is the program I'm with now. Um, but do I align with the clinical offering and the clinic? Like, can I believe it? And that's where my clinical degree itself comes in. Like, my master's in social work certainly comes in, and when someone tells me, "Oh, we're really client centered in what we do," I'm like, "Why?" Like, tell me. I'm not just going to take that on the surface. Like, you need to give me you need to give me reasons. And again, my being in the industry for a long time, like, I take with a grain of salt. Like, every time I hear about a place's reputation, like, I consider the source, because you can go on Google and you can see worst place I ever been to, best place I ever been to, one on top of each other by two people who both experiences are valid. So I try not to really let a few impressions or opinions about a place really shape my opinion. I take into consideration that we work with people who are addicted to drugs and alcohol and have mental health disorders, and none of them are usually on their best day when they come into programs like ours. So I take that into consideration. But I think experience helps more than anything, because I've had the opportunity to vet and work with these places now for going on 3.5 years. So the clinical programming is one that I kind of know off the top of my head. Like, how someone mentions they're going to this program, and in my head, I'm just like, I really wish you'd reconsider, right? Because like, I know, right? Or they'll say, hey, I'm going to this program, and that's a great program for you to go to, right? So I have the experience, I have the clinical training, but like, the other part is also, you need to consider the logistics. Like, you need to consider the insurance. Like, we are a commercial based insurance program, right? So, this is what I didn't know when I started. Like, I was a person who picked my insurance like a lot of Americans do when they get their first day and they're onboarding and they see, this takes the most out of my check every pay. This takes the least out of my check every pay. And I don't know what this means. I don't know what deductible means, co-insurance, out of pocket, anything like that. So working in commercial, you need to know what all of that is, right? So I, again, have worked in mostly an in-network place. Like, both places I've worked are mostly in-network. So again, it goes back to when someone calls me and shows me a picture of their insurance card, and it's a, Blue Cross Blue Shield HMO or EPO, I know where are options for them in the first place, right? And I think, even just being able to start with that, because they can call me and they can say, and their card can say on it HMO, and they're mentioning a place that they want to go to because they heard such good things about it, but I know it's an out of network exclusive facility, I have the ability to tell them, like, listen, if paying out of pocket's an option, we can certainly discuss that, and I can put you in touch with that facility. But if it's not, like, let me lay out for you what the best options are based off of your eligibility. I'm also taking into consideration when I'm receiving a phone call from a hospital social worker of a person who's an ambulatory concern. Like, I know the one floor facilities. I know the ones who are in network with that person's insurance if they need to stay in network. And I know the places that have ambulatory friendly facilities where, it's not going to be an issue that they need to use a sort of assistance, or if they are a fall risk, it's not stairs. You know what I mean? And that again just kind of comes back to experience and just knowing, like, we're going to try and refer this person to that program. Like, you're not going to be able to do that because that person has a co-occurring eating disorder and their detox isn't really the most equipped to be able to also handle what could very well may happen as a result of an active ED. So let's look into this direction because they do have a sister facility that maybe specializes in eating disorders, and they have more of a equitable ability to kind of detox them with that sort of a presenting comorbidity. Like, these are the things that experience alone has kind of given me. So I take all that into consideration, and again, what do you want? What is it that you're looking for out of this, right? The dad who calls me and says, like, I have 2 weeks off work and that's it, and I need to make it count. I know plenty of people who will try and sit there and argue with that guy, like, well, why can't you take a look? If you really wanted to be sober, you'd be willing to do it. It's like, dude, the guy's got 2 weeks, right? This is a social worker in me, right? Like, I can't tell the single mother who's raising 3 kids that she should go to detox if she really cared about her sobriety, right? So, I guess before I'm even discussing eligibility, I'm asking them what's their hope for the call. Like, what do they want? Do they just want someone to sit there and listen? I'll give them some time. You know what I mean? Like, I got to move on eventually, but like, I've had people just call me and just say, I need help, and then just sit there and tell me every reason why they need it but cannot get it. And I'm just like, I'm going to let you go, right? I'm going to let you go until you feel like you got it out. I'm going to hear them. I'm going to validate them. I'm going to say, call me back when your situation changes. And a lot of them do. And the ones who don't, that's fine too. But yeah, I mean, like, in order for me to find the right program for somebody, I got to know where they're at. I got to know where their head's at with what they're interested in doing, willing to do. And then after that, it's really experience. Experience kicks in. And, I work with an awesome team where we are in a group chat. We share a lot of resources together. Hey, so-and-so has this insurance, able to do this amount of time. Last use was this. What's their best option? And then we're doing what we do, and we're getting them hooked up to care as soon as possible.
So how do you determine whether somebody is a primary substance abuse or a primary mental health placement?
Yeah, I kind of do in my head refer both to the ASAM and the LOCUS, like, while I'm having conversations with them. I
What are
started
those?
in admissions. So the ASAM is the criteria that we use to identify an appropriate level of care for a primary substance use client. And the
Okay.
LOCUS exam is the same thing for mental health, right?
What
So
what are those? Like, what do they consist of?
um, so the LOCUS is a level of care utilization system, is what it stands for. And it's essentially like taking 6 criterias and breaking them down to see, the first of which is like, what's this person's debilitating life look like as a result of their depression or their anxiety, right? Like, are they saying, like, yeah, like, I've been feeling like a little depressed lately, are they like, I've not gotten out of bed in 7 days, right? Like, those types of acuity is kind of what you're using through the ASAM and the LOCUS to identify, right? So that's like, the LOCUS again is more so for primary mental health, that they're telling you that that they're unmedicated, but they know that they have like a schizophrenia disorder, right? Like, that right there is going to likely become primary to any like co-occurring substance use that's happening because it's an unmedicated personality disorder. Again, generalized anxiety, major depression, commonly seen with substance use stuff, right? So, I kind of just start by asking them, like, tell me what's going on, right? Like, for a person in my position who talks to the amount of people in vulnerable positions as I do, and I try to tell new marketers this all the time, like, you don't have to, we can still be human when we do this, right? And I started in admissions, and I I tell anyone who will listen, if you want to work in this industry, and if you want to work on the operations side or on the business development side of this industry, start in admissions, because there you learn everything. You learn insurance, everything from insurance to pre-screens and reviewing clinicals and getting information and working with social workers, all this cool stuff. Um,
So you
so
started right after college in admissions?
so I had to go back. I had to go back to college later because of my addiction. But yeah, when I
Okay.
graduated from when I finally finished my undergrad degree at 29, I started working in treatment pretty much like right after that. And I kind of fell into it. It wasn't anything I had set out or planned on doing. It kind of found me, and then I literally started grad school in the same like couple of months apart. And it's just coincided perfectly because I got my clinical degree while I worked in admissions and business development, and I was kind of faced with this, like, well, do I want to be clinical? Do I want to be business development and operations? And I found that I want to be both a little bit. Like I still get
Yeah.
to run groups and stuff, but like I do appreciate more of the less client facing and more behind the scenes stuff. And because of that, I've learned how to assess properly for primary mental health or primary substance use. And I usually just kind of ask the person, right? Like, and if they're telling me like how much they're drinking, and they're telling me that they're incredibly depressed because they're drinking, again, experience kicks in. It's like, okay, well, like, how much are you drinking? And they say that they drink a liter of vodka a day. I'll tell you, whatever's primary mental health or whatever's primary substance use there, it's not really going to matter in the first like 72 to 96 hours, right? Those first 3 to 4 days, because they got to be in a medically, monitored detox regardless, right? So if I work with a primary mental health program because the person's a vet and has post-traumatic stress disorder and is, more so drinking because of the PTSD, ultimately they're not gonna necessarily think that that's much of a difference anyway in the beginning, because they have to get detox before they'd be able to really do anything safely. So when we're talking detoxes, we're talking obviously benzodiazepines, opioids, and alcohol. If a person calls me who's using meth, or a person calls me who's using cocaine, like, I know insurance, right? So I know what their insurance policy is, and I know, unfortunately, if they're telling me that they're sniffing a few lines of cocaine every 2 3 days, their insurance is not going to say that that meets criteria for detox. So in my head right away, I'm like, all right, we're thinking residential level of care or PHP at the very max. We're not going to go down the route of detox unless you're telling me that you also drink at the same time, because then you'll at least provide a UA that's positive for alcohol in addition to the cocaine. That can change the insurance authorization. But finding out ultimately like what their behaviors look like, right? Because behaviors and diagnoses are not the same thing. So if a person's telling me that they have active SI and HI, okay, right? Like right there, that kind of stands out. And if they tell me that they self-medicate as a result of that, then I'm going to pry more into the SI and the HI and find out a little bit about what's going on there, and find out that the person has a long time history of a sort of personality disorder, a bipolar disorder, or something like that. And then I'm going to treat that more so as primary. It's another experience thing. Like I can't say like because I'm a person in recovery that I can usually sometimes feel it out, but I can. Like I can kind of easily sort through the BS. You know what I mean? Like when a 20-year-old's telling me that they're so depressed, but really they're drinking and partying like a college kid, may, or a person who didn't go to college when the rest of his high school class did, and he's dealing with a lot of the remorse and guilt about that, and this kind of like feeling lost in the sauce at that age. Like I can relate to all that. So I have the ability to kind of like identify, what is presenting as most acute in the short term is always the most important thing, right? The person telling me that they're going to harm themselves and they're drinking, I'm putting them into a place that's going to be able to 24/7 psychiatrically monitor them. Maybe not like a lockdown, like a 302 or anything, but at least somewhere that's going to be able to provide them with really adequate psychiatric care. But again, in the commercial industry, you're going to get that either way. And the social worker in me like hates to acknowledge that. That unfortunately, as amazing as the programs are in the Philadelphia area, the staff is underpaid and they're overworked. So it's hard sometimes, when a person I know has to go to a publicly funded program, because they have any sort of an active SI going on in addition to whatever their substance use behavior looks like. It's difficult. But for the most part, whether you go to SUD or mental health, I don't think it really ends up making much of a difference for, I'd say, 2 to 3 weeks, right? Within your first 7 to 14 days, especially if there's some substance use present.
Does it make a difference for the patient or for the
I'd say the
system?
patient. I'd say the
Okay.
patient. Yeah, I'd say the patient, because the patient, again, depending on the substance, 7 to 14 days, you're returning to a baseline regardless, because your body no longer now has the substance that you've been feeding it for however long. So the first 7 to 14 days is pretty much a medically monitored detox anyway, unless it is, again, a sort of methamphetamine or cocaine where there may not be these physical withdrawal symptoms like we see with benzos, alcohol, and opioids, but there's still a mental, for sure. There's still a mental withdrawal from any sort of a substance use that's so highly addictive, especially as one is meth. So 7 to 14 days is really like where a person is just kind of like coming down to a sort of baseline. So getting them to any sort of a residential facility is obviously the most important. But if they have, again, benzos, alcohol, or opioids, I need it to be to a place that has detox capabilities, because those people are going to ultimately need to at least be monitored 24/7 with a nursing staff and a psychiatrist who's able to treat the detox symptoms. But after those 14 days, it begins to show, like the primary begins to show. A person who is a primary mental health client over 2 weeks, now you cannot blame. And this is what frustrates me when people get diagnosed with like a form of, I don't know, personality disorder or borderline when they went into a hospital in a meth-induced psychosis. It's like that person's not a borderline. That person's in psychosis due to methamphetamine usage. But again, when you go out of 2 weeks from last use, it begins to show. It begins to show its primary. Not always right then. Sometimes people will go all the way through substance use treatment. They'll go 30 days of inpatient. They might even do like 2 to 4 weeks or even beyond that of like a substance use PHP program, where then it begins to be like, okay, this person's on a sort of medication that doesn't seem to be working, so they may need something a little bit more intense. And then even maybe with that, it may start to become like this person's more of a primary mental health client. We need to try and treat that now as primary. But in the beginning, like again, if someone tells me they need primary mental health residential treatment, but they're also using substances, I need to make it so that the substances are the main consideration at that point. Because again, I'm looking at what's going to get us through the next 7 days with you being safe, and what facilities are going to be able to accept you. Because there's certain primary mental health facilities that are just not going to necessarily be able to accept the person if they have a sort of detox requirement, whereas others do. So it's really about knowing that in the beginning and then just kind of letting the facility do what they do from there.
Does getting that level of care correct have any bearing or impact on like the organization at the organizational level, like as far as like performance?
Yeah, I think when you put an inappropriate person at a level of care, especially if they're too acute for it, I think you ultimately are asking your staff to treat a person who's not necessarily appropriate to be at that program. So, rarely do people end up in inpatients and residentials that don't meet that criteria, just because that's going to be what insurance reimburses the most for, right? Like when a person's at a 24/7 monitored program. So their criteria on the program itself needing to prove that level of care being appropriate for that person is a much more intense process, right? So if an insurance says we're granting a 10-day authorization for detox level of care for this client, they're pretty much appropriate to be there. That staff, that organization knows what comes with working with that sort of a milieu, right? That are fresh off their last usage and all that stuff. There's different behaviors that you see. There's different, there's just a different sort of a milieu at a residential level of care. But I've seen the lower levels of care try to be the appropriate place to treat those who are really more acute in nature, where they are in need of that higher level. And that certainly can create disruption amongst staff, right? Because if you're an outpatient program and you're working with a person who's, maybe beyond just, suicidal ideations and almost daily, they're kind of presenting as we're worried about this person's safety. A good program right there is saying, we need to do right by this client. We are referring them to that higher level of care until they can be safely monitored stabilized, and then, if appropriate, return to us. Um, but programs that don't do that, they keep this person who's not appropriate to be at their level of care. And it's not always psychiatrically, it could also be physically, right? Like some people could just physically not be a good fit for a program, right? I already mentioned like ambulatory issues, or maybe they're still just like detoxing a little bit, right? Like where it's, you took a person directly into PHP, like me. Like I overdosed literally, and then the next day I was in a PHP program. Like knowing what I know now, that's incredibly irresponsible. Whereas so the risk that that could cause organizations is certainly intense, but you know, again, back to commercial industry, insurances don't want to pay. You know what I mean? Like we're constantly having denials needing to be reviewed, where our clinical director, God bless them, and our clinical team are making sure that their documentation's on point and that they're submitting the right information needed for our utilization review analyst, our UR department, who goes and gets all of our authorizations. Like he's coming with the receipts, right? So it's like we want partial, and the insurance is like, well, we think IOP, and we're like calling you on it, right? Let's take this to review. And then even our CDs like getting onto a review with the doctor of the insurance, and they're looking at a chart. We're actually working with the human being. So I do think that the appropriate level of care is necessary to make sure that you're hopefully alleviating a lot of that BS, but you can only do so much. Like you kind of know going into it. So I prep my clients. Like if I know if they're coming from a higher level of care, I'm not saying it's a layup, but it's pretty often we're going to get that partial hospitalization, authorization. If they're coming right from the street, go ahead. I'm sorry.
Yeah. Well, you can finish your thought, and I'll.
Well, I was saying if they're coming right from the street and they say like, hey, and they'll say substance use, like, hey, I haven't drank in like 6 days, right? And I haven't used anything else, or 6 days is still short. Let's say they haven't drank in like 2-3 weeks, right? But they know they need treatment. You know what I mean? They've been white knuckling it the whole time. Like their life is still falling apart. They meet criteria to be in a program because they can't go to work, right? It's actually becoming a really big disruptor of their life, right? And I prep them. Like I listen, like I would love to get a PHP authorization for you, which is at our program Monday through Friday from 10 in the morning until 2:30 in the afternoon, right? However, if we don't, I just want you to be aware, we are going to be able to then get an intensive outpatient program authorization for you. And in the event that's what we do, you are not going to be PHP, you're going to be IOP. Here is the difference. Here is an explanation. Here's why. And listen, we can't guarantee, because we can't get prior authorization prior to the event, because we're giving, the BPS, we're not just giving like a pre-screen. So if a person calls me and does a pre-screen with me tonight, it's not like I'm able to submit that to the insurance first thing in the morning and get like, yeah, we'll authorize PHP for this person, and then I call him back and say, hey, you're good, come on in. Like it's kind of taking a chance. It's like they come in, go through the process, we submit the claim for the authorization, we hope to get the level of care that we're admitting them into, all based off of, again, the criteria that we go by.
So, do you get that clinical financial feedback loop, like when they're, denials, or when there's like those authorization? Talk about that.
Financial, they get on the front end because it's their insurance. So financial with us is we do what's called a verification of benefits. So a person calls me with their member ID number through their Blue Cross Blue Shield employer policy with their name and date of birth. So that is one thing that we are able to do, that verification of benefits, so that they can at least know what the financial breakdown is. So that is not like, we'll see. Like, and again, that's back to the ethical piece, right? Like, I realized that when I was calling around places to go to treatment, I didn't have $2,000 sitting in my account. You could bet your ass I wasn't going to treatment if I did, right? So, we do need to, though, ethically let them know what their out of pocket responsibility is going to be, right? And we need to work out how that's going to ultimately be rectified. So, there is the financial piece that's understood on the front end, and we communicate that to the client so that they know what a deductible. I take my time. What's your deductible? What's your coinsurance? And what's your out-of-pocket maximum, right? And if they don't know what those three pieces of information are, they do by the end of that call. What I always am able to say to them is like, listen, That's your insurance. I'm not making these numbers up. Like, I'm not making up a $2,000 deductible because it sounds good. Like, that's your policy, unfortunately. So there's always a little bit of an understanding of the insurance piece because we are in the commercial space where, like, ultimately people know that, it's not going to be free. So the financial piece, they'll know. The clinical piece is a comprehensive pre-screen, I call it. It's a 20-minute phone assessment that the client will do with an office manager at all of our locations. And that's a surface BPS. So that's the demographic information. That is what is going on, right? Like, what is the substance usage at that time? And we ask to how much are you drinking? And if they say, I don't know, it's like, how much are you spending, right? And if you're spending $20 on vodka a day and you're drinking cheap vodka, you're drinking a lot of cheap vodka for $20 a day, right? So, it's always harder in this market, especially too, because there is a lot of illicit substance use. So there's a lot of how much, pardon me for saying so, but I get real with the people I'm talking to. So I'm like, how much dope are you doing? If they tell me like that they're shooting dope, I'm like, how much dope are you doing? And they're like, I don't know. I'm like, how many bundles are you going through ultimately, right? Like, I'm able to kind of relate to them again on that front. So I'm identifying all that. So like our office managers are kind of taking all that information into consideration. Do they have any diagnoses? What their treatment history is, because that's big in both the LOCUS and the ASAM. If either of them have had a lot of stays in treatment, they are most likely to qualify for a higher level of care because they are considered more of a risk because they're repetitive in this, right? Whereas at the outpatient level, if same person calls me and says, I haven't drank in 3 weeks and they've never done any form of treatment before, and I go to try to get a PHP, the insurance is likely to say, well, why don't they start an IOP and see if that works? Because they don't have the record, if you will, that it's been unsuccessful in the past. So we do our best to get as comprehensive of a picture as we can of a person when they come in. And this is where a very key distinction between primary mental health and primary substance use comes up. Because as comprehensively as we get a mental health referral, at least on the front end, you never really know. Whereas substance use, again, we all kind of have our BS meters on, like we can kind of feel things out. I'll let somebody know, like, hey, there's a good chance this person may show up sauced and they're not, you know what I mean? Like, so let's be prepared for that. So we are. So they come in, they drop a hot UA. We're like, listen, you're not appropriate to be here. Let's get you to a higher level of care. Let's get you safely stabilized. And then you can come back and resume after that. But the mental health is different. So like if a person's coming from a higher level, that's one thing because I'm getting all of that clinical information. If they're coming from a psych hospital, I'm getting all of that clinical information. And that's what we're using to review to make the determination on what level of care with us they'll be and essentially who we're getting as a client. But I have people who call me and they say, I need to do this. I've never done anything like this before. And I need to use both the locus and my experience to identify, like, is this a person we can bring directly in? I yield to my clinical director. He's got more experience than me. But we're taking the client a lot at their word, and then they show up and they present differently.
So when you talk to these potential clients
Mm-hmm.
and they're talking about like barriers in their life, as you
Mm-hmm.
kind of mentioned before, um, these barriers, which as you said, they could be like legitimate things like childcare,
Yeah.
transportation, that kind of thing.
Mm-hmm.
Have you noticed any patterns with the kinds of barriers that they talk about and the kind of treatments needs that they'll have?
Yeah. So the most common barriers, and again, important to keep in context working in commercial industry because it is different than working for a public program, right? The main barrier that we come across is work, is that inability to miss work. And I'll ask them, like, do you have short-term disability coverage? Do you have Family Medical Leave Act coverage? Because if so, I'm not saying that you should be okay with just leaving work, but you can't say that you can't because you'll lose your job because we know now that at least is not true. So work is the main barrier, I'd say, when it comes to the substance use side of things. The ego of I can do this myself, I can stop drinking on my own, stuff like that. Like we'll always deal with that. Mental health, I think the most common barrier is I kind of see like a lot of I see two different extremes in mental health. I really do. Like I see the person who does have like their generalized anxiety and depression who could they benefit from going somewhere and sharing for a couple of hours in a small group setting with a primary therapist and seeing them one on one in a course of a week too? Like absolutely, right? Like you're kind of, mild generalized anxieties, major depression could really benefit from a program like that. But then I see like those who do have like, you know, borderline, bipolar, like more intensive clinical diagnoses that come from a higher level of care that usually need more because we provide housing. So like they maybe need more of wraparound services and case management services. And a lot of them are younger, right? Maybe they're in their early 20s or they're 19 and stuff, and they're kind of like what I call failure to launch clients at a certain point too, where like they're at a point of their young adulthood where if they were tasked to go and live on their own, like they probably would not be able to. Um, and I think that barrier exists amongst the client, but I also think it exists amongst the family,
Well, housing is a pretty
where
big barrier for a lot of
oh, for
people.
sure. Oh, for sure. Yeah, absolutely. And again, less as much in the commercial space because they're either gainfully employed where they have their own place to live, or I mean, listen, it's a privilege thing at the end of the day, right? Like let's just call it what it is. As two social workers, let's just call it what it is, right? Like a person who's of lower socioeconomic status who does not have commercial insurance is more likely, as we know, right? Social determinants of health like are more likely to find those types of barriers. The homelessness or the housing insecure barrier that I come up with is a mother saying that their son is not welcome to return home until he's better. So is he homeless? Technically, absolutely, right? But at the end of the day, like he's on his mom's insurance. And this is back to like that piece of privilege where when I was running groups, like I was never afraid to say like you don't realize how good you have it. You know what I mean? Like, you don't real like you're in a program with master's level licensed therapists that are offering you this incredible treatment. Like I've lost so many friends who didn't have commercial benefits when they died. Not that if they did, they wouldn't have died, but like when I went to my last rehab, I was walking up and down the street of Camden, like calling places that were telling me, call me back tomorrow if we have a bed. Right. And I'm like, so like that's not what the commercial space is. Like the commercial space is if I have commercial benefits, I can call three places until I can find that I can have a detox room to myself with a TV in it, right? So like there is this sense of privilege that comes along with it, and it's certainly not everybody, but it's certainly seen as opposed to seldom ever really seen in the public sector. So the barriers are kind of just that too. Is like this idea that I have options in and of itself has presented a barrier where, I have seen, and this is what breaks my heart. Like I have seen in my 4 years roughly in the field, like I've seen people who've just seemingly existed in different treatment centers in a cycle essentially, right? Like they get sober, they get 4 or 5 months, they're in a program that has housing with IOP, they relapse, they're out for a while, they just call a detox, they go back, they go somewhere else. And like, when clients report like what programs they've been to as part of our assessment, I'd say conservatively like at least 50% are underreporting because so many of them just kind of forget all the ones that they've been to at times. And I think that's a fault on the industry. I think that's also kind of like us creating a problem that we also are the solution for, admittedly. But I also think it's for those who are under the age of 26 who are still on their mom and dad's insurance. Life has not shown them the consequences that await them at that 26th birthday, right? Like where the insurance says you're no longer legally able to be on mom and dad's insurance. And now private places like mine are no longer options to them. It's a whole different ballgame because now they're working in a place, they're going to places that are not nearly as nice. The food's not as good. The therapists aren't paid as well. The beds aren't as comfortable, right? Like all that's true. And there's this realization of like, damn, like you know what I mean?
Yeah.
Good.
So does the talk about that for a minute. When you talk
Yeah.
about these luxury sort of amenities, do
Mhm.
do they mean better outcomes? Like, do they mean, more clinical excellence?
I wouldn't say so without the data. That I'll say. Like, I wouldn't
Okay.
feel comfortable saying it has better outcomes without me being able to prove the data. Um, I can certainly say it makes for better experiences, like while in treatment. You know what I mean? Like, and again, I think this goes back to the social determinants of health and everything else as well, right? Because if I know that my insurance is going to permit me to stay in this level of care at least as long as I can until I'm able to therefore then go to a lower level of care that will most likely offer housing accommodations as well, I have less to worry about while I'm at residential treatment. Whereas if I got sober on Medicaid in New Jersey, shout out New Jersey, because their Medicaid program for me was fantastic. The problem is ultimately when I went to this rehab, I needed to find a place to live afterward. And like, yeah, a case manager certainly helped me and a therapist tried to certainly help me. But at the end of the day, like, come that last covered day by the state of New Jersey, if I didn't have somewhere, they were opening the door with my bags and I was free to kind of go on my own. Now that's as true in commercial, but the difference being if I walked out of a place with commercial benefits and call someone else, maybe back to the unethical marketing that exists, I call somebody else. I'm like, yo, I just left treatment X and I need to get, and like they run my VOB real quick and they see that I have active coverage. They're sending an Uber to come scoop me to take me to their program. And like, this is kind of what we know is out there kind of happening. So I wouldn't say the data and the outcomes is better. It might be. I will say though, like the starting salaries are higher. Public places can't always afford to have strictly master's level therapists. So with that just comes different experiences by the providers. You know,
Does that
the
make a
heart is
difference
in
that,
it.
like, from
I
what you've seen?
What I've seen is that clients still have this negative connotation of a therapist who's not also an addict or an alcoholic in recovery. And I don't mean to generalize when I say that, but a lot of times people are under the impression if I'm trying to get sober and my therapist isn't in recovery, then they don't know what it is. And I always hit them with like, yo, if I got cancer, I'm not asking my doctor if he ever had cancer when he's trying to treat me, right? So like you can debunk it like that, if you will. But I don't think it's a metric based off of care. That's for damn sure. I've seen public places, especially in this area of like Philadelphia and the collar counties where the epidemic has hit us harder than most, right? Like if I see one more person wanting to like go put Kensington on their Instagram because they're trying to draw attention to it, like I'm gonna throw them against a wall. So it's just like because I'm tired of seeing the exploitation of people like me, right? Like, but when those people eventually, hopefully, go and get help, I will say that the public places are like, that's like where the heart, that's the trenches. That's really where like the heart is. Um, but they're publicly funded, or they're nonprofits. So yeah, there's a difference. You know what I mean? Like, I don't think anyone there would call them luxury places, but I always say like I got sober in one of them. You know what I mean? Like, because it's about the intention as well as the person who's going in. The difference is like a person can exist in a commercially insured treatment program displaying zero motivation, really no intention on changing, and they're unfortunately oftentimes enabled through the process either by the program, certainly by family, because family at this point oftentimes are kind of done, right? So they're like, he ain't my problem, you know what I mean? Like he's there, he's kind of their problem. Not always though is like rehabilitation kind of taking place, you know what I mean? So yeah.
When you have these housing programs that you're working with,
Mm-hmm.
um, but also just in general, like these community partnerships that you
Mm-hmm.
create, just working with this population, um, how much does that play into like I guess I should say like your marketing approach and how you're talking to like kind of positioning yourself as a resource as opposed to just
Yeah.
kind of like a referral funnel.
I think what's nice is that I can tell the people like, look, I'm able to help you with whatever you want. Like if you just want to talk to somebody, like I'm putting my kid down in an hour. Let me call you back. And you can just talk to me, right? Like I can offer them that. But if they're calling me because they just left the rehab and they dropped the ball, they didn't set them up with aftercare, or they said don't set me up with aftercare, I'm going back to my wife, and then they get out and the wife says you ain't coming back here, and they call me like I just need a recovery house, right? Like I have recovery houses, or I need a recovery house and an aftercare program, right? It's like I know aftercare programs that work with recovery houses, and so I do think community resources are amazing. In my area, it's a huge focus on like street outreach and all that, which is incredibly needed and awesome. Um, I do though think providers like myself and resources like myself, we have to be more comprehensive. You know what I mean? Like I'm paid not to put people just in my program. Like I'm paid to be a resource to our community. And that's why I work for the organization that I work for, because they understand it and our values and our goals align. Um, but street outreach is incredibly needed, but it's also it's like it's focused. Like you're there in Kensington to feed, provide harm reduction supplies, and do what you need to do. They have some resources, but like they're volunteers often at the end of the day, right? As are a lot of community based organizations. Um,
Wow.
so when I'm contacted, it's more so like, okay, again, let's get to what is most needed in the short term and let's start talking what are eligible options. Don't call me and tell me that your boy from treatment went to this place and that's where you want to go if you're also telling me you're on a form of MAT. Because I play golf with the owner of that recovery house and I know that he will not accept MAT, which is his prerogative to not, right? Like, so again, you could still see your boy, but like we need to find you an option because of the situation that you're in, which is you're on a Vivitrol injection or you're on a Suboxone, prescription, right? So like let's find you the option that's a fit for you, and I think that's where a resource like me is invaluable in the space. And again, it comes back to the experience because I can save people time, right? Like I'm not in the business of trying to tell them like what you want's not possible, but I am always willing to tell a person like, if you want to live there, you have to come off what you're on, plain and simple, right? Like, or if you want to get out of your area, you have to change your Medicaid over to this county. Here is a program that can help you to do that,
What
and kind of being more of a resource like that.
what leads programs to decide where they stand on MAT?
Um, well, two answers really. One of them is if they're a publicly funded program that receives Pennsylvania state funding, they have to. They have to receive. They have to be MAT compliant. They cannot not accept MAT, and that's from residential programs down to recovery houses. So, um, if you are a recovery house in this area that wants to be able to even receive referrals from organizations that are public organizations, that are Medicaid places or private places that take public funding, you have to be someone who will accept a person on MAT. If you want to have a licensed recovery house, I did my master's project, my final project on this topic, because I don't believe everyone should have to. And this is where, admittedly, I wear many hats in my own life. I wear my marketing hat, I wear my clinical hat, I wear my recovery hat, and they all conflict. I'll tell you, like, I'll tell a client on the phone, hey, whatever you need, I'll help you to get. If I see the same client in a 12-step fellowship that I'm a member of and they want to talk to me, I'll talk to them with a completely different hat on. And I'll tell them that. I'll say, listen, I'm not the marketer or the therapist here. Like that's not work me. Like personal me feels this way about certain things, and that's okay. I've compartmentalized all that myself in my head, and I think businesses are ultimately ran the same way. If this program that I'm very friendly with the owner of, he's incredibly successful. He's been open for over 10 years. It's his prerogative to say, I believe in recovery this way. And he's not, and like, this is where admittedly, like I have sometimes kind of combated with harm reductionists or with other social workers. Like I remember being on a social work panel where I was made to feel like I was wrong in telling people at lower levels of substance use care that they needed a higher level of care, because some of the others on the panel were, you should meet them where they're at. If that's, I said, I'm not putting a person who's actively nodding out in an outpatient group among other people who are trying to get another day sober, right? Like, I'm putting that person in a higher level of care. And if I'm wrong for that, I'll be wrong for that, right? And I think, again, like kind of the business is around the same way. Like, my friend is prepared to say, I'm not taking any state money. I don't care if I'm not a licensed recovery. He operates legally still. It's all legal, it's all licensed and everything like that
Sure.
through the
Yeah.
county that he's in. But he's not able to receive referrals directly from certain organizations because he doesn't, allow MAT in his program.
So there are some people who say that MAT is trading one addiction for the other.
My view on MAT is simply this. I have personally seen probably over 40 friends and family die, right? If a person being on a form of MAT is preventing their mother from getting a phone call that they found their son or daughter in an alley in Kensington, Camden, or God knows anywhere else, I am 100% on board for that.
Mm.
Whatever is going to keep that mother, that husband or wife, that son or daughter from hearing that their loved one has suffered an overdose and is therefore then dead, I'm all about it. I do, though, personally think that there should be a plan in place, right? Like, I do not see it, and this is my opinion, I do not see it as a long-term solution to things. Is it trading one addiction for another? That's a subjective question. It's a good question. That's a subjective question. But I've seen people who take all of the steps in their own recovery as someone does who's not on any form of MAT. Who am I to say like that person's a better recovering than that person? You know what I mean? And being in a 12-step fellowship that I am, the concept of service is of great importance. Um, who am I to say of whom I should be in service to? You know what I'm saying? So like that's my opinion on it. Like, and again, like I'm not, and I've had clients see me in meetings because I used to work in the same area that my recovery meetings were in, and they'd come and they'd talk to me after, and I'd like have to stop them and be like, "Yo, like this isn't like the Joe you see and run groups with. Like, this is a different person." And they've asked me that, like, "Well, what are your views on things we do?" And I'm like, again, if it's helping, then fantastic, right? Like, I don't believe that the person who goes to treatment one time should be leaving on a form of MAT. I just don't, because there's avenues not yet explored, in my opinion. But someone who's been to the same program 2, 3, 4 times and has never left on a form of MAT, let's review this. Let's look into this as a potential option for you. You know what I mean? Because maybe there's a pattern that you have, which is one that I had, which is I get out and use the day I get out. If being on a form of MAT allows you the ability to get past those initial bumps that you usually find yourself falling over, could be a good thing.
I
People
and
who are on it long term, I don't know.
I am with you 100%, by the way, but it sounds like the way that you approach sort of like how you market these days is informed by your background, your experiences, like you said. Um, and so tell me about sort of like how you go through your decision making. Like,
I mean, I think I consult. I consult it all. You know what I mean? Like, well, first thing, and this is just kind of like, I wouldn't even say it is. I guess it's an unwritten rule. Like, if I get a referral from another marketer, it's not my referral. Like, that's just the name of the game. So, like, if a person sends me a client and says, "Hey, can you take this client?" and for whatever reason we can't, that's not my client to refer somewhere else. That's, you know what I mean? Like, that's kind of an unwritten rule. Like, I go back to that referral source and say, "Hey, unfortunately, the client's insurance isn't accepted here," or the client's got a really acute psych diagnosis, we don't feel appropriate kind of coming here. So like, that's experience, because I've made that mistake where like I've thought that because the referral came to me, like if I know of a better resource for them, like I've connected the person, and that was wrong of me to do, and now I obviously know that. So I think to get started, you have to kind of know the rules of things, right? Which again goes back to start in admissions, because that's where I ultimately learned that. But yeah, I mean, I think that what makes a marketer an ethical or a good marketer is that they're willing to admit that they don't know everything. And I sure as hell don't know everything. I know a lot more than I did 3.5 years ago. I know a lot more than the person starting today because experience is the best teacher in this. Um, but yeah, I think for me, it's really about I've had the privilege of working with amazing people, like working with amazing people. So like my staff now is fantastic and they come to me for things. I get to go to them for things. And where I started was the same way. Like I learned under two different executive directors. One of them's an executive director of a substance use and mental health residential, and the other was an executive director of a substance use and a mental health outpatient. And I worked for an organization that had multiple facilities across multiple service lines, multiple levels of care. And I watched these leaders and the way that they led. I watched the way that they made decisions. I watched the way that they consulted. I watched the way that they were willing to be told that they were wrong by their staff and the way that they received that. And I was so like, and they tell me like, this is a decision I'm making. And if I'm wrong, Joe, you can tell me I'm wrong. And I did. I eventually I got to a point where I felt like I was comfortable that I could do that. And
How'd
that's
it
the same
go?
took. They respected me for saying it. I don't know if they changed their decisions. I mean, my leadership team now, like, you know what I mean? Like they're awesome, but they're not above being wrong. And I think that is where this industry needs to always be, right? Like we need to exist in the space that we do that allows for the collaboration of other people. And other programs, in my opinion, that fail are whether they really fail, like they go out of business, or whether they just like, in my opinion, for whatever that's worth, like they just can't seem to achieve this sort of a reputation that they're maybe in search of, or hopefully they'd be in search of, because one department overrides all, right? Like admissions and operations essentially tells the clinical side, like, we're bringing this person in, and clinical doesn't have the ability to be like, this is a mistake. Like I've seen that, and I would never, not to say I would never work with an organization like that, but back to experience, like I could be offered a great deal of money to go work at a certain program where I just know that my values don't align with them and the way that I know them to do business. And I'm just like, I'm not interested. It was hard for me to leave the company I started with because I was there only for 3 years, but it was where I started. It was where I worked with these amazing people, but an opportunity came to me by people that I already knew and worked with in a referral capacity and vetted and got to know their leadership team. And, I would not have left the place I left for many options, but this place was certainly one of them. And I'm really glad and fortunate for my own career that I did.
Well, it sounds like you were well supported.
Oh, I was. No, I was. And I
Yeah.
think, and I think that's kind of sign of good leadership is, like you don't want to ride. And this is why I'm not yet in the position to kind of manage a team, but I'm looking forward to that in my career at some point, because I think the best compliment you can get is when you manage a team that is eventually kind of get to this point where they need to go and do something with everything that you taught them and put it to use for themselves to eventually manage a team for themselves. And and this space is awesome. And I take for granted, I guess, that because like we have events a lot, and I'm not at a lot of them, but like, there's events where like, 30 people, 30 different programs will come, whether they're conferences or CEU events and things like that, marketing luncheons and stuff. It can get old, you know what I mean? It's a lot of the same people, a lot of the same talk. But like I try to remember in those moments to take a moment to like appreciate, like, man, like I've met some amazing people. Like I've met some really amazing colleagues, some of whom I would now consider friends, and we get to work in this space that all of us have our own personal connection to, whether we're in recovery. Some of us are, loved ones and people. Some of us have lost family members and friends who are just so moved to do this work. Um, but
Mhm.
like, I think we all realize that, like, whether you do it ethically or unethically, like you're kind of dealing with people all the time. It's some of their lowest moments of their life. Like you need to be able to kind of balance yourself and all that. And I think we support each other really well in doing that.
Um, Having that personal connection, it sounds like um, kind of has helped you make that distinction, like kind of be your compass in making
Mhm.
those ethical choices.
Yeah, like having my personal experience in addiction.
Right. Just like, well, yeah, as kind of somebody that's experiencing that system, as well as
Mhm.
somebody that's, trained as a social worker.
Yeah.
And then so you come into, that marketing world and that marketing
Mhm.
role with, this very specific kind of background.
Yeah. Yeah, and I mean, there's a lot of social workers that work in marketing, and I feel like I try to at times, admittedly, I try to not stand out as if I'm the only one by any means, but like I'm proud of us, like because I think when we take a very clinical focused degree, right, like micro social work or direct practice social work, like the majority, I don't. Maybe some of us went for like macro, but I don't think so. You know what I mean? Like, so we go for this direct practice, degree. But yeah, I mean, like it does. It permits us to look at situations differently, maybe than some, and that's a lot of why we first connected. Like I'm interested in content that you write. I'm interested in my wife as a
Thank
as a
you.
registered nurse in an ICU, and I see my wife experience a lot of what you share about as a provider, right? Like and I experience a lot of it, and I think that's what makes me proud to be a social worker in this space is some would say obnoxious enough to want to say the things I feel like that need to be said, and it's certainly gotten me to a position where, I mean, when I came on to the new company I did, it was very much laid out for me in the beginning. We like that you had the ability to look at this from more than just one perspective. Like you don't just consider it insurance eligibility and what are options and do just the marketing thing. Like you have this clinical degree and this background for you to also consider this stuff. But also, again, like, there are marketers who have been in the field longer than myself, and some probably been in shorter than myself, who are just as good, better, right? Like not this, you know what I mean? Like they do the same thing without the degree, right? Like, and that's a lesson in life. Like you don't need the piece of paper; it's over here somewhere. You don't need the masters in social work, like
Right.
to
Yeah,
think and to live by the code of ethics that we know, right? But yeah, I really think it's the personal experience too. You know what I mean? Like wanting to
for
see
sure.
people get well, wanting to see family members healed, you know what I mean? Like whatever the healing looks like for family members. That's a big thing for me because of the amount I put my own family through. So, I'm always really excited to talk to moms and dads and husbands and wives, and they ask me a lot, like, like, well, what was it like for you? Because I'll tell them, like, this is why I don't know if I could be a therapist, because I'm very willing to lead with my own, scars, if you will, right? And direct practice, we're kind of told like it's about the group, not about you, right? And I have a hard time doing that. So it's like, if they ask, like, well, how many times, how many times have you been to treatment? I'm like, I don't know if you really want to know that because you're telling me your son's going to his second program, like, and I'll tell you, I went to 12, right? It's not to say he has to, but they want me to be vulnerable with them. And, I'm proud to get to do that with families because I think they're often the forgotten piece. I think the numbers are, and you can probably correct me, but I think the numbers are roughly 20 million individuals diagnosed with substance use disorder, give or take. And last I checked, it was an average of 4 to 8 family members or affected loved ones per person diagnosed. So
So
it's a lot of
that's a
people.
lot of need. It sounds
Four to
like.
five times the amount of people have family members struggling than those actually struggling.
So I wanted that touches on a point that I wanted to ask you about.
Mm-hmm.
What do you have to say when people say that the assumption that getting people into treatment, like just more
Right.
beds equals more revenue?
I mean, I'd say it does. It does in the sense like if I have a census of 50 people and I have 35 in treatment, I'm getting reimbursement rates for 35 of them. Whereas if I add 15 more people to those 15 open beds, I am ultimately going up by at least 50% of my billable rates, if you will. But I don't think that size computes to success. You know what I mean? Like I would say that the programs that I've seen that are the 100 plus bed programs, your data is always going to be a little misconstrued, right? Because you have that many more people, so you have that many more chances of outliers and variances and stuff like that. But I think that kind of I think that this industry has a sweet spot. You know what I mean? Like, and I think um, if you're trying to push it to the most amount of people as you can, and your clinicians are getting 13, 14, 15, 16 to 20 people per caseload, it's like, can't tell me that's good. You know what I mean? Like, they're getting burnt out. How much individual attention is that client or patient getting? Um,
Right.
so
And then
I,
that
I
affects organization reputation and
everything. Yeah.
like patient
Yeah.
outcomes, dropout rates, I'm sure.
Yeah, outcomes are interesting. I think that's again what initially drove me to your content is outcomes are incredibly interesting because I think what's happening, not I think, I mean I see it. What's happening in the commercial space is because there is still and once was the wild, wild west of out of network reimbursement rates. I think insurance companies are really starting to tighten up in our industry. Where I think where was once this like if you have out of network benefits, you can go wherever, right? Like that's what a PPO is. That's what out of network is. I've seen recently multiple states say if you have a PPO, even in this state, you cannot receive substance use treatment out of the state. And I'm like, that's crazy because that's literally what a PPO should allow them to do. And I will never say, but I side with the industry because I don't, with the insurance because I don't. But I can kind of see what they're getting at. You know what I mean? Like I can see when they're getting, and I've read indictments and I've poured through records myself and I've seen these billables and they are criminal, like quite literally because I read them in an
Literally.
indictment. But like, yeah. But I think when you have the insurance really like tightening up on that in the way that they are, I think that's where your outcomes comes in, right? Because if eventually the space is, and it'll never go fully to an in-network, but whatever the percentage is now, the out-of-network providers to in-network providers nationwide, right? I don't know what it is. It'd be an interesting question. I think what will begin to happen is there will begin to be more in-network providers than out-of-network because I think these insurances are going to stop reimbursing in the amounts that they are for out-of-network billables. So when that comes, that's when outcomes and data is going to be the most important because how am I as an in-network provider going to differentiate myself from another in-network provider? I'm going to need the data and the outcomes to go to that insurance company to want to renegotiate my rate and say why I deserve for it to be more than all of these other programs that don't have the data that I may have. So outcomes based measurement, hugely important.
It's a
And I think
long-term
it's,
game.
yeah, it really is. But I'm seeing it already. I'm seeing it already. Um, it beginning to be, even just going on LinkedIn. Like, and again, I don't have this huge amount of years in the space, so I don't know if this was always happening, but I always look forward to the end of Q1 because I always look forward to seeing programs' outcome data. So they're taking all of their data from the year before and they're putting their outcomes report and they're ultimately saying, like, look at our outcomes. And it's like, okay, that's cool. Like, let me look at that. That means more to me, being the nerdy social worker I am. That means more to me than their marketer telling me how good their program is. You know what I mean? Because I'm cynical a little bit. Like, you are paid to tell me how good your program is. Let me look at your data. You know what I mean? Like, let me, they're not opening their CRMs or their EMRs to us, obviously, but like, let me look at your data. Let me see what measurements you're actually measuring, right? Let me see what sort of systems you have in place. Let me see what tools
Show
you're
me the
using to
receipts.
measure. Show me exactly. Show me the mistakes. 100%. Show me where you're coming up short. Show me where you're willing to say this is certainly something where I know that we need to work on. Like that because then you're human, and that goes back, and I posted about this a little bit ago. That goes back to one of those executive directors at my previous program who'd come to meetings with me, and the person across the table would tell him all they love about his program, and he'd be like, "No, like I didn't come here for that. I need you to tell me what we need to do better." And I always took that. I always took that away from meeting with him. But yeah, I think outcomes it's the next thing. It's certainly the next thing, and it needs to be. It needs to be because we need to start to sort out all this riffraff that's coming. And again, I am so new in this that if anyone listens to this who's been in this field for a lot longer than me and is like, this kid doesn't know anything at 34 years old doing this for only 4 years, they're absolutely right. But I'm smart enough to know that I've seen things go in a direction in even just a short amount of time since I've been in the field, where there's some stuff getting tightened up on. You know, when you ruffle the feathers of the insurance companies in this space, like that makes things happen. That makes things move. You know.
For sure. I'm gonna wrap this up. I wanted to ask you though, just for the audience, where can they find Q1 outcomes reports?
Well, so what they should do is a lot of them are posted on LinkedIn.
Okay.
A lot of programs are posted on LinkedIn. Google, honestly, Googling like the larger behavioral health providers in the country will show that right there. Like your
Okay, so it's just
larger
like
behavioral
out in the
health
open.
providers. Oh yeah, oh yeah. The larger behavioral health providers, they want you to know it. They really do. Um, and then if you know anyone listening to it, if you know your space, if you know your market, if you know the providers that are in the area that you're in, go on their websites because they'll post it on their websites or they'll post it on their LinkedIn's again. And it's cool. Some of them are short and sweet. You know what I mean? Like 6 metrics that they release some scale that they did, and you know, and but then others are a lot more in depth and a lot more kind of specific, which is cool. But yeah, it's that time because we're wrapping up the end of Q1. So usually they spend the month of January and February going through all of the last year's data from January to December. So usually around like March, you'll start to see programs beginning to release 2024's outcomes data. So
Awesome.
yeah. Hmm.
Okay. Thank you so much.
No problem.
Congratulations, by the
Thank
way,
you. Thank
on
you.
everything.
Thank
How
you.
many years have you been sober?
So, in the spirit of transparency, I did have a relapse about 3.5 years ago. It
Okay.
was the best lesson I learned. I was about 14, 15 months sober, and I was working in treatment at the time, and I had a slip that lasted, thankfully, only one night. My support group rallied right back around me, and it didn't go beyond that one night. But yeah, I mean, it was the best thing that could have happened to me, honestly, because I didn't know where my recovery was lacking. Then this incident happened, and it made it very clear. Thankfully, again, my network kind of rallied around me so that it didn't go beyond that. And I just celebrated 3 years of December. So I'm back to 3 years and 5 months, or 3 years and 4 months, just about. So yeah, it's been a
Amazing.
ride. Thank
In
you.
just 3 years, you're already touching so many lives and making
Yeah,
such of an impact and so much of a difference. So
I appreciate it.
you're
It's cool. Like I said, I've watched a lot of friends unfortunately perish as a result of this, and I have no good reason why I didn't. So I just try to channel all that into, you know, kind of living their legacies that they unfortunately are unable to do. And
mm,
it's a real kind of like you know, sentimental purpose behind everything I do, but it genuinely is that. Now, underneath the floor, in the third floor of my little Philadelphia row home that I'm living in, is a 16-month-old son that's sleeping beneath me, and that's like my entire world right now with my wife and I. So it's truly a blessing. Recovery is like the coolest thing. Working in the field is awesome, but it also does come with the need to again kind of compartmentalize and recovery me, work me, husband and dad, and you know it's all the consequences of the blessings of recovery are awesome, but they're certainly a different type of showing up for life today. That's for sure.
well, at least they're better problems than what you
For
had
sure.
before.
1,000,000%. And thank you for this. This was honestly, it was such a pleasure to connect with you on LinkedIn. And I, as you can tell, I don't shut up. I love this stuff. I love talking shop. I love talking, you know, social work. And what I do and what I'm so passionate in doing. So I appreciate you giving me this opportunity to just kind of talk about the industry that I see as the industry. And it could be different to other people, but that's what I see, and that's why I'm so passionate about what I do. So thank you for this opportunity. It was really cool.
Well, and I'm sure our listeners will appreciate it. I appreciate it. Have a good
Thanks.
night.
You too.
Bye.